G'day, I'd like to let you know that Aussie Med Ed is sponsored by Tego. For most doctors, indemnity insurance is one of their biggest costs of practice. While many doctors are still with the same insurer they joined in medical school, many have made the switch to Tego and benefited from it. The team at Tego have told me that those new to private practice could qualify for 4 years of discounted premiums. To find out more about Tego, visit tego.com.au. That's tego.com.au. G'day, welcome to the Australian Medical Education Podcast, or as I like to call it, Aussie Med Ed. This is where I get to interview different specialists in different areas of medicine and ask them about different conditions, including diagnoses, investigations, treatment options, etc. Really, in these COVID times, it really replaces the actual general chit-chat we used to have around the corridors or in the tea rooms of the hospitals, and actually gives you an idea of a pragmatic approach to these different conditions and makes it more of a fun way to get a bit more information. Any questions that you might want to put to me can be put forward to me at gavin@med-ed.com.au, and I'm Gavin Nimon, the host of this podcast, which I'm hoping will be educational in a fun and relaxed fashion. I look forward to bringing you this information today, and thank you for listening. Well, thanks again. Once again, it's nice to have you on board in our first educational podcast, this time based on a gastroenterologist and discussing the topic of jaundice. In this particular podcast, we interview Dr. Sandy Craig, who will talk to us about his approach to assessment of jaundice. We'll look forward to speaking to him later on. Hi, I'm Gavin Nimon, the host of this podcast, an orthopaedic surgeon based in Adelaide in South Australia. The idea of the podcast is to provide information to you after interviewing and speaking to consultants in the area of their specialties. Obviously, this is not my main area of expertise, and as such, the information provided is of a general nature and really more of a chit-chat sort of conversation to get an idea of how a real-day person treats a condition. Please take on board that this information provided is of a general nature, not thought to be considered as general medical advice, and nor should it be the only way of treating a particular condition. Obviously, the general practitioner or medical student listening to it should supplement their knowledge by this podcast, but also refer to resources and consultants in the area around their specialty. I'd like to begin this podcast by acknowledging the traditional custodians of the land on which this podcast has been produced and pay my respects to the elders both past and present. It gives me great pleasure to introduce our first guest on Aussie Med Ed. He's a gastroenterologist who undertook his undergraduate teaching at Adelaide University from 1986 to 1991, then completed his advanced physician training both at Royal Adelaide Hospital between 1993 to 1997, obtaining a PhD at Flinders University and working on biliary motility from 1998 to 2000. He's a BMO at Flinders Medical Centre until 2017, and he now works in private practice in Adelaide. I'd like to introduce Dr. Sandy Craig, who is my special guest on gastroenterology, who's going to talk to us about the assessment and options of treatment for jaundice. Sandy, how are you doing?
Good.
Thanks very much for coming along and being our first guest on Aussie Med Ed, Australian Medical Education Podcast. It's great to have you on.
I'm looking forward to it.
Excellent. Now, you're a gastroenterologist. You obviously see a lot of general complaints, but jaundice is one that's been raised by the medical students to me about how to assess it. Obviously, it encompasses a large group of conditions, and I just really wanted to know your approach to assessing a patient who might come in jaundiced and how you'd go about assessing them. And obviously, we're talking about the adult population as opposed to neonatology ones.
Look, I was grateful for your idea of the rule of threes, that you always try to break things down into ways of approaching it so that you can remember things. And you can try to look at jaundice as prehepatic, hepatic and extrahepatic, but in simple terms, it really is either in the liver or it's a blockage of the bile ducts out of the liver. So the key from my point of view is obviously to take a full history, in particular asking about the sense of whether or not there's been any infective event, the drug history, also about non-prescribed medications. There are some over-the-counter herbal remedies that can cause hepatitis. Obviously, alcohol, something you need to consider. And then whether or not people have pain, because painless jaundice versus someone with a history, perhaps a biliary colic that could then suggest common bile duct stones, is an important part of the history, especially in the older person who could be at risk of even having cholangitis. So I suppose that the key is a good history on examination, trying to look for any signs of toxicity, but Also, whether or not there are any signs of chronic liver disease to try to work out if this is an acute on chronic situation. And then the crux of it will usually come down to the liver function tests and imaging to look at the bile ducts. And once you've got those things in play, you can usually then start to work it out as to whether or not it's a liver problem or a problem in the bile ducts.
Yeah, that's a great point. I think you bring up the idea of the history really being the most important part of it, and you've outlined a pretty good aspect of the history. You mentioned though medications that are bad and can cause this. Which ones particularly should we watch out for?
Well, I suppose just any antibiotic can potentiate it. The classic commencing of anticonvulsant medications, and obviously if someone's in a more acute situation, if they've had paracetamol poisoning or overdose, they're really the main ones. And there's some unusual things like anabolic steroids, some cardiac medications, but they're the main ones.
So most of these medications probably wouldn't affect the average person, but there's some people who can have a hyperreaction to it or can accidentally take too large a dose, and this can cause issues. What about the infections? Obviously, I was brought up on Hep A, B, and C, and at the time when I was training, Hep C was a bad diagnosis, but now I believe it's curable. Are there any other type of new acute infections that we need to watch out for?
I suppose we're always on the watch out for hepatitis, severe hepatitis A, and because it might then cause more infections with other people, but not really, Gav. I think most of that stuff's unusual, although it's fascinating the number of people that actually have antibodies to hepatitis A, meaning that there are many people who develop hepatitis A as some sort of viral illness but never actually become significantly unwell or jaundiced. Glandular fever in its severe form can be associated with an acute hepatitis and CMV, but it's pretty uncommon. I've only ever seen severe glandular fever causing jaundice on a handful of occasions.
You're heading on to about the obstructive causes with biliary disease. Obviously, when I was training, we saw a lot of cholecystitis, gallstones, yet for some reason I haven't seen it come across it that often in practice. And I don't know if I've ever met anyone, both privately through my friends or as any of my patients who have actually had it. How common is gallstones and cholecystitis in the community? Is it a common thing? Is that one of the major causes of jaundice?
12% of autopsy studies, in autopsy studies, 12% of people have asymptomatic gallstones. So it's pretty common gallstones being present in society, but it's those unlucky people where the gallstone can get into the biliary, into the bile ducts and obstruct it. And that really is a situation that particularly junior doctors need to be aware of, because an older person presenting with jaundice and fever, cholangitis can be lethal. So understanding that is a really important situation to be aware of is critical. Most of these patients, I think, though, come through A&E departments, Gav. So that's probably why you don't see it in your practice. But cholangitis is a worrying diagnosis.
So of all those ones, which one's the most common thing that you'd see in your practice?
Yeah, so I suppose we worry always about pancreatic malignancy. In terms of pancreatic malignancy, it's more that painless jaundice, because if you do get a pancreatic cancer that's obstructing the bile duct, it tends to be quite early and not associated with pain. And there's a classic clinical sign of a palpable gallbladder.
So pancreatic tumours, are they very common, Sandy?
The early pancreatic cancer involving the bile duct is one of those rare situations where you can actually have a successful outcome with pancreatic cancer treatment, because the jaundice is an early event, classically associated with a palpable gallbladder. And I assume it was a Frenchman, Courvoisier, who described that sign. And the important aspect of that sign is that if people have had a history of gallstones, the gallbladder tends to be small and contracted and won't dilate. So that's often a bit of a classic exam question. But no, pancreatic cancer, and then the rarities in terms of bile duct tumours, such as cholangiocarcinoma, which is not very common. But in terms of malignancy, metastatic cancer in the liver causes a bit of a mixed picture of cancer, sometimes with nodes around the bile duct compressing the bile duct, but also if the liver becomes extensively involved in metastases, it develops its own form of what you'd call intrahepatic cholestasis.
Okay.
So no, they're probably the most common. And then the classic being the cirrhotic person who then decompensates and becomes jaundice. That's a very common cause.
Excellent.
If you just come back to your earlier question of how you define it, you're really trying to work out if it's an intrahepatic or extrahepatic problem. And I would initially do blood tests looking at the liver function test, and if it was a transaminitis with an ultrasound not showing bile duct dilation, then you'd head down the pathway of investigating liver causes.
Right.
If the bile ducts were dilated, you immediately look at, and the liver tests were suggestive of cholestasis with a raised ALP and GGT, you then head down the pathway of more careful examination of the bile ducts, usually with an MRI of the bile ducts or MRCP.
Right. What's an MRCP is an MRI with?
Well, it turns out the biliary secretions can be carefully managed by the MRI machine to give you lovely pictures of a cholangiogram.
Okay.
So ERCP is only really now a interventional procedure to either put a stent in or to remove stones.
Gee, they used to be so common.
Yes, no. Well, so MRCP really has taken over that space.
And how often do you need to do intervention to remove stones, or how often a cholecystectomy is required of all the people who get some jaundice? Will most of them require something like that in that scenario? Or
so I think these days, if the surgeons are far more skilled at trying to handle both removing the gallbladder and trying to remove common bile duct stones at the same time. Although it can be a tricky situation because if you operate on the gallbladder and you don't decompress the bile duct, you run the risk of the surgical clips not holding. So more often than not, people will do an ERCP prior to cholecystectomy to ensure that you've got good drainage of the bile ducts. But how common is this stuff? It's happening that there'd be several lists a week of ERCP at most tertiary centres for bile duct stone removal, or mainly to put stents in malignant strictures as a way of decompressing the system and relieving jaundice.
Okay. We talked about examination before. What parts do you really want to look at when you're examining a patient?
I suppose you're obviously trying to examine just get a feel for how big the liver is, if it's tender, which is more common in acute hepatitis. In particular, looking for signs of chronic liver disease and all those classical things, starting with the hands and working up the arms to the head, looking for pulmonary erythema, clubbing, Dupuytren's, bruising, suggesting coagulopathy, spider nevi in the chest and cheeks, gynecomastia for a sign with cirrhosis, assessing for splenomegaly, which could be either tied up with an infective event or a sign of chronic liver disease with portal hypertension. So you're really trying to assess all of those issues.
Okay. What about something like Gilbert's syndrome or Gilbert syndrome? I'm not sure how it's pronounced nowadays, but is that? I believe that's quite common.
You had a bit of Frenchy about it.
Yeah, well, I thought it did actually. Yeah, I thought it was Gilbert, but is it Gilbert's?
No, I've always called it Gilbert's, but look, it's thought to affect maybe 5 to 10% of the population. And typically, these people, this is now getting into the concept of the isolated elevated bilirubin. So all the liver enzymes are normal, but you've got this bilirubin that's typically about 30 to 40. And if you fractionate it, you can work out if it's unconjugated or conjugated. And if it's predominantly unconjugated, that's classic for Gilbert's. Although it's important to always have a look at the blood picture to make sure there's no signs of hemolysis. Obviously, hemolytic conditions will cause an unconjugated hyperbilirubinemia, but Gilbert's is undoubtedly the most common cause of an isolated elevated bilirubin. And
will they cause jaundice in that scenario? Or
yeah,
is it?
not commonly. And what will typically happen is sometimes someone with Gilbert's will be given a medication or just get a viral illness or just have maybe a few too many drinks. And they might run a bilirubin of up to, say, 70 and be mildly jaundiced. And there's the rare cases where people will become obviously jaundiced. I've got a general rule of thumb that the icteric or, sclera becoming jaundice, you've got to have a bilirubin of about 50 to 70. And then once you get a bilirubin of more than that, it might start to become apparent in the skin. But they rarely get bilirubins of more than 100. But Gilbert's is thought to affect 5 to 10% of the population, so it's pretty common.
Interesting thing with this is once your patient does present with jaundice, how is it treated? Apart from treating the underlying condition which causes it, is there any way of actually improving or reducing the bilirubin in the system and excreting it?
It's mainly in people with extrahepatic obstruction, and that's what I was talking about with the ERCP and the interventions you can look at with stenting to get drainage out of the bile duct. And that's really important because people can become very, very distressed with itch when jaundice is persistent. And particularly people with malignant causes of jaundice, trying to make sure that they get drainage is critical. And it also, once you've got drainage, it means the risk of cholangitis decreases enormously.
Any other tests apart from MRICP or the blood test that the students need to be aware of?
Obviously, always assessing people's liver function, their synthetic function by looking at their INR, their albumin, looking for any signs of liver failure with hepatic flap, signs of ascites. That's always important to have a sense of people's what's called the child's score or the child's Pew score. That is really an assessment of how the liver is compensated or uncompensated.
Well, thanks, Andy. I think it's been a fantastic rundown of how a real-world physician treats jaundice. Really appreciate your advice, and I hope the audience has found it very useful. Once again, it's been great having you on the show, and for those listening, Dr. Sandy Craig, I really appreciate his advice. He's one of the nicest guys in medicine and a very pragmatic approach to how jaundice can be assessed and treated. Once again, thank you very much, Sandy. It's been great having you.
You're very kind, Gav. Anytime. Okay.
Thank you very much.
See ya.
Once again, I'd like to remind you that the information provided in this podcast is really a supplement to other sources of information, such from research and from other consultants in the area. And the information provided today is of a general nature, not specific to a specific condition or a specific patient. A person listening who's trying to find out more information about their particular condition should always consult their general practitioner or seek specialist advice. Realise that the information provided is in a general manner and it's not considered as a part of a general medical consultation. And any further information provided should be treated in general and in no way provide individual clinical advice. Well, thank you very much for listening to our podcast, Australian Medical Education or Aussie Med Ed. It's been a pleasure giving you this information, and I'd like any further feedback or questions directed towards me put towards gavin@med-ed.com.au. Any questions on a particular area of medicine will be directed towards a specialist in the area. We'll make it as a part of our podcast the next time. We look forward to hearing from you. And once again, we'll look forward to the next time you might listen. Thank you once again. Aussie Med Ed is proudly sponsored by HealthShare, a digital health company that provides solutions for patients, GPs and specialists across Australia, and Tego, offering medical indemnity insurance for doctors. That's tego.com.au.